So, as you were all very well briefed earlier in the plenary by Dharmendra, we are all here today to discuss the 10 policy choices for a renewed social contract, as it says on the cover of your program. Those policy choices are available in publication on various places on site today, if you want to read more detail. But basically, this is the focus of our entire discussion today. Specifically in this session, you will see the title, Building Resilience, Strengthening the Social Agenda and Health for Societal Progress. And specifically in this session, we will be looking at policy recommendation number 6, asserting reducing inequality and improving social mobility as policy goals, and policy recommendation 7, engaging the private sector earlier as an actor for social good. Now, I don't have to remind anybody in this room of the old adage that good health is true wealth, and I think that that's a good kind of framing for our session today. We all saw how the COVID-19 pandemic underscored the crucial interconnection between health, well-being, and resilient societies, highlighting the significance of health for social cohesion, for justice, and a robust economy. In Europe in particular, ailing public health will increasingly pose financial burdens, whereas a healthy population can drive advancement. What we're going to be discussing today with our 4 panelists, all of whom are coming at this issue from different perspectives, is that intersection in terms of our healthcare systems, but also the social good and the resilience of our societies. So I'm very much looking forward to the discussion. But bear in mind, as I said, those policy recommendations when you're thinking of how you're going to contribute to our wider discussion after our initial speakers. So first of all, I would like to welcome Frank van den Broek, who's the Belgian Deputy Prime Minister and Minister for Health and Social Affairs. Frank, my question to you to open up the discussion. The EU's role in health has grown significantly in recent years, and the term resilience has been used a lot in this context. However, are we now ready for the next crisis?
Thank you. Thank you for having me here. I think the answer is that we are slightly better prepared for some types of crises, like a repeat of COVID, but we're certainly not ready. And let me say that the introduction, I think, was absolutely spot on for this session, because I think we should be aware that we will be confronted with major, large-scale, transnational crises, much more than in the past. So that will be part of our life. And so we know from the COVID experience that to address such a large-scale crisis, you need both resilient welfare states, resilient health systems, say at the national and regional level, but you need also collective action at a higher level. You need international collective action, you need European collective action. And so to answer your question, I think at the level of the EU, pretty important initiatives have been taken in response to COVID. The European Health Union package, including, for instance, the creation of HERA, the Health Emergency Preparedness and Response Agency. However, and to cut short a longer discussion, I would say that whilst the promise of the European Health Union as posited by Ursula von der Leyen was broad and rightly so. So it was about the role of the EU in health and healthcare. So far it has focused very much on health security, on emergency preparedness. And that's too short. I think we know that you cannot dissociate health security, preparedness for emergency in a narrow sense, from the overall quality of your health and healthcare systems, the resilience of the systems. And you cannot dissociate that from the health status of people, because we know that a more healthy population is also simply more resilient. So we have to combine also at the level of EU action, preparedness. There's still a lot of work to do because the legacy is pretty messy, I should say, in terms of institutions and agencies that have been created. That's one issue, which we will address during the Belgian presidency of the EU, the first half of 2024. But we have to add to that also action at EU level on the resilience of our health systems and on the health status of our population. Let me just, for the sake of time, take one or two examples. We are preparing our Belgian presidency of the EU with a clustering of themes. One is about care, so healthcare. One is about preparedness, and one is about the security you need, for instance, with regard to the supply of medicines. I won't go into that, but that's a very, very, very urgent and difficult issue, which we are now really addressing at EU level, is about shortages of medicines. But coming back to care, just to take that point, I happen to think that not only all EU member states are confronted with a very structural problem of shortages of workforce, which is really structural. It's not only COVID, it's a structural issue linked very much to demographic aging. And I also happen to think that the development of strategies to cope with shortages of workforce should also be done at EU level. The EU has often been at the frontier. And it's both about innovation in the way you invest in your workforce, the way you organize your workforce. And there we have to really break a number of conservative resistances. It's also about technology. And we might discuss this. It's also about the kind of technology you can combine with innovation in processes to address shortages in the workforce. And there, I think the EU level is an excellent level for mutual learning, for supporting strategies. Let me finally say that the EU is also a pretty important legal player, because everything that's got to do with the recognition of professional qualifications, also for the health workforce, is EU competence. And one of the issues in the agenda, which we have put forward for the Belgian presidency from January onwards, one of the issues is that we also would like the Commission to reflect critically on the current legal framework with regard to mobility and recognition of professionals. Because that framework is an internal market framework. It's not exactly well equipped to accommodate the kind of dynamic evolution we need in terms of the organization of the workforce. It's not an easy issue, but that's really something we have to address, given also important competencies which are there at EU level. I'll stop here maybe, but that's the kind of reaction I immediately have on your question.
Thanks, Frank. Lots to consider there in terms of the forthcoming presidency. Turning to you next, Lubna Bouarfa, CEO and founder of Okra. As you mentioned in the plenary, you are a scientist by background and you work at that intersection of AI and healthcare right now. My question for you, Lubna, is what key trends and challenges do you see at that intersection of AI and healthcare that are likely to shape the future of the industry? And how can these be leveraged to strengthen social progress in healthcare?
Thank you, Mary. Since I started working with applying AI into healthcare back in 2007, building a kind of autopilot in the operating room, actually, as an early scientist, I realized the biggest barrier to bring AI into healthcare is human adoption. And if we look today, we're much ahead. AI is booming in different industries. And the biggest barrier for us is to really bring what we develop in the lab as AI, digital solutions into healthcare to the practice, to the patients. We already proved in literature AI systems for detecting tumors, for breast cancer, for everything to do with imaging in dermatology, in ophthalmology is already not only fully automated, it's already outperforming the human in these sectors because it has the ability to learn from thousands of data. And why don't we already have those systems as standard care practices in our hospitals? I think if you ask me the trends are, I would describe it as innovator. Many innovators like me has seen these possibilities, how we can innovate healthcare, how we can create healthcare system that doesn't wait for people to get sick, and that we can predict risks, that we can predict treatments that work, not only using the best data that could be genomic and imaging, but even using simple data like transactional data, workflow data. That is our limitation right now. We can do all of this. I describe it as waves in the ocean, yeah? And this wave is getting bigger and bigger and bigger. But there is no shore which is gonna splash. Actually, the shore is big rocks of data barriers, big rocks, high risk. Healthcare is high risk, let's regulate. Big rocks of every member state wants to have their sovereignty on healthcare. We don't want to share data. Well, healthcare is the place where we need more data. It's an evidence-based industry. Some diseases don't have enough samples in one country. So imagine these big waves is growing and growing and growing, and there is no ocean where it's gonna splash. So what is gonna happen? We already saw it happening before with the internet. Yeah, so this internet become and more people use it, and suddenly a lot of scammers on the internet, which created the big tech companies that came to solve the chaos. So this is going to happen again. I see it coming, very close. So we are at a crossroad. We have two choices, and the policymakers can choose which one. The biggest risk is to do nothing, because we know exactly what's going to happen because it's happened before. So we are at a crossroad. Either we're going to create a shore for this innovation where to splash, and that shore is what we call, as engineers, sandboxes. Open some hospitals in Europe for us, share data with innovators. Let's start already bringing those systems, those diagnostic systems, those prevention systems, those computing risks. Let's start having them in number of member states. Let's show that next to the standard care treatments with a doctor, these AI systems can do also a good job. Let's bring these results to Parliament, to member states, and convince everyone. Let's go to the patient. If we don't go to the patient, the big tech will go. Let's ask citizens to donate their data just like they donate their blood and their organs to create a unified, sovereign EU healthcare system that prevents us from getting sick, that doesn't wait for our population to get sick. That is number one. If we don't do anything, we know it's going to be an app and not governed by us. It's going to be maybe one, maybe two, where our children will go get free healthcare. They're going to talk to a doctor, we don't know which jurisdiction. They get medication prescribed from any jurisdiction. They can go to those labs, share their data. That will be the price. And we can't control how is data going to be used, and selling more ads or even more other things. So we are at this crossroads, and I really urge the policymakers. The biggest risk is to do nothing at this stage. Thank you.
Thank you, Lubna, and thank you for injecting that sense of urgency to the discussion as well. We'll turn next to Nicola Schmidt. Nicolas, you are the European Commissioner for Jobs and Social Rights. My question to you is, how can Europe further prioritize workforce issues and improve working conditions in a bid to enhance healthcare system resilience?
Yes, thank you. Thank you very much. I just wanted to say I was very much impressed by the previous presentation on climate change. We should really present that presentation everywhere, because there are still people who do not believe that climate change is a reality. Now, I think we are now confronted in the European Union with a general problem of labor shortage. And this is becoming one of the biggest issues for the future of our economies. Yesterday, there was a report presented in Germany and one of the major problems of the German economy is labor shortage. We're limiting the growth potential in Germany, and this is something which is shared more or less by all member states in the Union. And when we are looking at the sectors, different sectors, there are many sectors affected by labor shortage and skills shortages, and obviously the care sector in general, and especially also the healthcare sector, is affected by this labor shortage, as Frank has already mentioned. Now, there are different approaches I think we can develop. First, I would say that we have to change a bit our health policies in that respect, because we have gone through a period where cost effectiveness in the care sector in general and also in the healthcare sector was priority. And we have reduced everywhere more or less the workforce. And labor conditions, working conditions, have worsened, sometimes dramatically. So in many cases, the attractiveness of this sector has been lowered. Second, I would say we have in many member states, I do not know about Belgium, a very strange system of education and training for people in healthcare. Very limited numbers, much lower, by the way, than the needs, or at least the objective needs. To enter faculty of medicine is not impossible, obviously, but it is more and more discouraging for many young people who would like to become doctors, but who fail because of all kinds of barriers to enter the faculties. So this is probably some kind of a protectionist way, or it's just to limit the numbers because of the cost consequences of that. So really we have to rethink the way how many people we train for these professions, really. And that's about doctors, but even about nurses. There is also the question how the distribution of responsibilities between doctors and nurses is organized. So sometimes nurses could do jobs which they cannot do for any reason. I would not enter the details, because they are reserved to doctors. So the organization, and Frank certainly knows much more about that, the organization in our health system could be also helpful. The third one, I would really approve what you have just said. I think there is a huge potential through technology, because this health or care in general, we consider this as sectors where productivity gains, and this is a horrible economic concept, but nevertheless it's useful. Productivity gains are not very huge. I think we get now the possibility. Said, artificial intelligence helps us a lot and is much more efficient than, because it can be based not on thousands or even millions of cases. So I think we have really to go that way. That's indispensable, not just to save a workforce, but also to make our system much more efficient, much more sure, and also to increase the preventive aspect of our health system, which is also something extremely crucial. The fourth one, certainly, if we have done all that, probably we need some kind of mobility. But in the care sector in general, including healthcare. But that's a very critical system, because if when we look already today, in Europe, you have more doctors with African origin than more or less in Africa itself. So there is an issue there which is very critical, because we can say, okay, we attract all kinds of doctors from third countries. Well, that's fine for Europe, but we have also to be aware of the consequences on the countries these people are coming from. The same thing, we see it now on the care system inside the European Union. We attract many people, mainly women, from parts of Europe where salaries are low, very discouraging, to the countries where salaries are not fantastic, but much higher. What happens? Well, they come, and they are replaced by people coming from outside the Union, be it Ukraine, Belarus, or other parts. So we have to manage this mobility in a fair way.
Okay.
And sometimes also this mobility helps to keep salaries down and labor conditions down also. And I think this is a big issue, how we have to restore the prestige, the recognition. It was one very important moment, that was the pandemic. Everybody applauded. That's an essential profession. And now, well, I would not say this has been forgotten, but well, we have gone to business as usual again.
Right.
And I think with the recognition in our societies of these jobs is essential. Last word is?
Very
well,
last word.
Yeah. we are in a situation of big shifts in the labor market. Probably artificial intelligence will affect many professions. And there will be also reductions in labor force in sectors. And we have to organize these reductions and the shifts and the mobility from one sector to another, including to healthcare, to care in general. But this will only be possible and successful if the quality of work, if the recognition of work in these sectors can be improved and recognized in society at the level it should. Thank you.
Thank you, Nicholas, and particularly for opening up that multifaceted question of mobility, as you mentioned. Very interesting. We'll turn next and finally to Andrea Rapagliosi, who's the Senior Vice President of Public Affairs at Edwards Lifesciences. Andrea, my question for you, what solutions can the international private sector players like Edwards Lifesciences offer to alleviate healthcare workforce challenges and help standardize technological development and use across EU member states?
Good. That's really, we fly high. But let me, I like to be pragmatic, concrete. I think, as has been said, what the private sector is able to do is to produce innovation, right? Is our technological know-how and our contribution to society. That's really the element. Advancement in science translated that in something that the same society can use, can apply. As the Minister van der Broek clearly said, there is an innovation of products, technology, but there is also an innovation of processes. You cannot put, sometimes I used to say, the best, actually in Belgium would fit very well, the most modern, technological, fantastic bicycles so that you can have, I don't know, 100 grams of bicycles, you can change the speed with just simply thinking, etc. And midday on a Friday in the traffic jam of Rome, my hometown. It doesn't work. It doesn't work. You know, you cannot really make it happen or deliver on the expectation. So innovation is critical, but it's critical this combination. And I think that also innovation is no longer anymore an option. Maybe 10 years ago, we were still saying, do we need that approach or that therapeutic approach, or we can do differently, etc. Today is really a necessity to transform healthcare system. What has been referred about healthcare worker scarcity, there's an interesting study by Gupa Strategies in the Netherlands produced a couple of years ago. It says that to maintain, today in the Netherlands, 1 out of 7 people are healthcare workers today. If we want to maintain by 2040 the same in the next 15 years, the same level of healthcare without changing processes, without change, the ratio goes 1 out of 4. So can you imagine that a system where you have in the Netherlands 4.5 million people working in the healthcare system? It's not even not conceivable, but not sustainable from any form of so it's there where the innovation should impact. It should immediately bring inside in process. I use always 4 Ps to describe that. We need an innovation in system that are more preventive, inform better, are more predictable, and I think and predictive, if I may say so. So technologies that allowed us to understand the disease and the risk stratification in order to allocate better the resources upstream. These are the information that AI and many other systems, but also a model of early detection of disease, etc., can provide. Should be more personalized, customized on patient needs, but also personalized in sense of customized on local needs. More participatory, shared decision with patient allowed better choices and facilitate the process, and in a way more pragmatic in terms of evidence-based, but also making best use of all the data that Lubna was referring that we may have in terms of real-world evidences. You heard many times we collect an amount of data, but actually through the legislation that I see at the horizon arriving, it seems that rather than facilitate, I'm referring to the European Health Data Space, we introduce actually more barriers to the accessibility of this data. So in a way, we invest in generating more data, but then we complicate our life in having access for planification and for decision making. So just to make a very short, I think that innovation should be at the service of patients and healthcare workers, that's for sure, but actually the big changes, if we combine the best use, the innovation of processes, is also being at the surface of efficiency and sustainability of healthcare system. That should be really the next steps at the next level of looking at innovation in healthcare.
Thank you very much, Andrea. So lots to chew on there from our 4 speakers. We're going to open up now to the room. And just a few rules of engagement before we do that, because the clock is against us, alas. So basically, raise your hand to be given the floor. Please introduce yourself before speaking. And I would encourage you, no speeches, prioritize questions to the panel, or if you have specific recommendations in terms of those policy choices we mentioned before. I would also like to draw the attention to Sophie, who is our Debating Europe facilitator in the room, and she will be ensuring that citizens' perspectives are also part of the conversation. So, hands up, who would like to contribute? Okay, great. We have you were the first, I think. If you could introduce yourself and
Thank you so much. My name is Thomas Alvin. I work at FBR, the European Federation of Pharmaceutical Industries. Great panel. So I have a very particular question. And I think the minister put it very well. You know, health resilience is much more than pandemic preparedness. We need to strengthen the overall health systems. And there are investment needs, and you all touched on some of them. At the same time, we see now health budgets contracting again, and you know, OECD has new numbers. We're getting to even below pre-COVID levels in real terms of health spending. So the money doesn't seem to be there, but we have investment needs. And usually this leads to just a cut of cost across health budgets, and we know that has a bad impact on health and the long-term outcomes. So how do we fix this? And because we all know that investments in health, where it's in AI, new therapies, workforce, it will take a long time to translate into better health outcomes for people. It's not the same year. It's in 5 years, it's in 10 years.
Okay.
So how do we create a new investment framework where we can invest knowing that we will not get a return this annual budget cycle, which is how most health ministries or finance ministries operate. So how do we get into longer-term perspective on health finance?
Great. I'm going to take questions in batches of 3. So there was Kieran.
Kieran Devan, Coventry University, but I'm also the chair of the Irish Health and Social Care System. We began to touch on it. I would love to see the Commission take a lead on supporting the change in the model of healthcare, because we all live with systems which are aimed to fix you. You know, you need an antibiotic, you break a leg, you have a heart attack, you go into hospital, you get fixed, go home. But in the future, where, you know, life expectancy being what it is and where it's going, we will have a lot of people who will, you know, we will not be able to be fixed. It'll be about how do we manage, you know, increasing frailty. It strikes me that that could be something that the Commission can take a lead on. How do we nudge systems to focus more on care in the community, not only prevention, but also that kind of how are we going to handle the frail elderly? Because that's where the big volume will be, and all our systems are built around big buildings called hospitals. How do we get those services distributed? Thank you.
Thanks, Kieran. One last question in this batch over here.
Thank you very much. I'm Brikena from the Lifelong Learning Platform, European Civil Society for Education and Training. I was a bit curious to hear a little bit more from you from one of the visions that we try to promote, which is to avoid this top-down policy making. We're talking about resilience, but most of your speeches were how to convince people to adopt something, how to train people to do something. So we are looking at citizens as someone or as people that are actually just impacted by what we decide and what we do for them, instead of what they are and what is their role in shaping what we are doing. When it comes to AI, for instance, where is the actual role of citizens in shaping it, in shaping the policy about them? So I think we have to question a little bit the way we do policy and the way the role that we give to citizens. So I would like to hear from you a little bit more of policy that is more people-centered and how we can change that, because we cannot bring people to education and training by forcing them. We cannot bring people to AI or whatever. Or we saw it during the pandemic with the vaccine. So we cannot just impose people's decisions.
So first of all, I'm going to ask Nicholas to take Kieran's question first, and then we'll go to the rest of the panel. Nicholas.
Well, first I have to say that the Commission initially has not very much high level of competence in healthcare. That's the first point. We finally, I would say, due to the pandemic, suddenly became an important actor in healthcare or in health policies, because obviously pandemics need a broader and transborder approach. So, and now we are talking about a health union, by the way. We do not like to talk about the social union, but we are talking about the health union. Health union being part normally of a social union. So that's the first thing. And I think there is a need now, and also awareness, that we have to work much more between European countries in this area. Now, in this approach you define, we have started to give some reflections on care, how care should organize. Because we are talking about healthcare, but it's also long-term care for different categories. And here the Commission has made recommendation, because we have for competence reasons, how this care system could be organized. And there is one important issue also, which is the medical deserts. We have in many parts of Europe more and more, especially rural areas, no medical service. And here I think we, in our territorial approach, cohesion policy, this is one element where we have to think how to organize this. And here obviously also online medicine is of importance, because this gives new opportunities. My last point is also away from this which we need for different diseases and so on, but also more community-based. And here I think what we call the social economy can be a good solution, because they are social enterprises, small entities taking care of people, giving social care services. I think this is something we should develop, and this is in the framework of our recommendation and the action plan of social economy. So going in the direction of more community-based social services in general, including health and care services.
Thank you, Nicholas. And I'm glad that you raised the question of medical deserts, because actually they disproportionately affect older populations across Europe as well, as you mentioned, rural populations. Andrea, you wanted to come in terms of...
And I think thanks a lot for the bottom-up request. When I was playing with the 4 Ps, one is participatory. I think what we have experienced, and again, are still, I would say, episodic, but when you engage, system that engage, process that engage, shared information with patient at the moment of the diagnosis through all the circuit of the treatment, system gaining in efficiency. You use less day, you have better outcome, you gain that type of time. So it's not only, it's nice to inform a patient. There's a project run, it's called MIT-MEVA, but anyhow, it's funded by Europe, by the European Union under the EUREGA program, is the management of aortic stenosis in Catalonia they've done. And they measure how was managed this disease before, so they collect data, historical data, obviously, the time between a diagnosis to treatment, the time before getting to the hospital, the time in the hospital. And when they started to introduce in this program a full information at the diagnosis of the patient, how the patient, they were managing their health. So actually became, it's not only, when I say participatory, it's not only directional or something nice to have. It's effective. It impacts the famous process innovation I was referring to. And there is here the chairman. I'm honored to be member of the board of the European Patient Safety Foundation. Pernille is there, and I think they've done a lot on that field, and they should be recognized.
Great. I'm going to go back to the floor for another 3 interventions. As I said, comments, policy recommendations, or questions to the panelists. So this lady over here is first. Do we have a mic just over here? Yes. Yes, we'll come back to that.
Thank you so much. I'm the person Andrea referred to. I'm the president of the European Patient Safety Foundation. And I think patient safety is something that we don't talk about that much as we should, because lack of training for healthcare professionals and lack of staff, of course, is a question about patient safety. And I do think that is a common way for the European countries to work together to really assure also that people like to stay in healthcare, to work there and feel that they are, appreciated as any other members of society working in a successful environment, really, because healthcare is so much affected by everything. And I would like to take on also another hat that I have. I'm appointed by the European Commission, thank you, to be a member of the European Cancer Mission Board. And as maybe some of you know, that we have a European Cancer Plan. And it's assigned by all countries in the European Union to really work with and for implementing the cancer plan. And it's a good example, I think, that we should spread also to other areas of healthcare, because it's one mission, but it's also 4 other missions were appointed at the same time for climate and environmental changes, and how cancer in this particular area is also affected by this. So we can connect all the things together to have a more sustainable European Union. And of course, that will also affect the other countries around. So together we can do it, I will say.
Okay, great. And over here, Mike.
I'm Oana Tsoiu, former chairwoman in the Romanian Parliament of the Labour and Social Protection Committee. I have a question based on Commissioner Schmidt's input on the social services connected to healthcare. In my country and in parts of Europe, a century ago, if you would be sick, sometimes the doctor would prescribe a month in the sun, walk in the forest, go closer to the seaside. I'm not saying go back in time, but I'm saying there are some lessons there in the ecosystem around the patient and the potential patient. Nutrition, sports, access to nature. And my practical question to that is, what do you see at the national or European level in the future as mechanisms to be able to finance that, as mechanisms to be able to train professionals in this more multidisciplinary approach where movement, social interaction, nutrition, the environment around are used as instruments for better health outcomes connected to the healthcare system as we recognize it to be today.
Thank you. And another hand, just here, this lady here.
So just a question about, I agree with all what was said about the importance of the offer of social and health services, and especially the health desert. But in addition to that, I would like to know, in the perspective of the new cycle, European cycle, how do you feel, or how do you envisage the link between the offer and what economists call care economy as a parameter of define and also to allocate resources to health services globally? So Is care economy something just for the economist, or people from health system and health responsibility are part of in order to define new parameters for social and health care globally, especially the fact that care economy is a gender-based economy, especially for women. So that's also something which could be important in this perspective.
Okay, back to you, Frank, in terms of the health budget question earlier.
Yes, yeah, thank you. I'd like to address several questions that have been raised. First of all, I agree with Thomas that we badly need to be convinced everywhere that we have to invest sufficiently in health and healthcare. I'm working on that message at EU level, at OECD level. There will be an important ministerial in January at OECD level, which I have the privilege to chair. I will drive that message home there also. We have to invest sufficiently in healthcare. There is a particular difficulty at EU level because the fiscal governance, the economic and fiscal governance of the EU, as it is being discussed right now, does not seem to give sufficient leeway to this kind of investment because it's simply accounted as a cost factor and not as a productive investment. We are discussing this. During the Belgian presidency, there will be a joint meeting, we call that a jumbo council meeting of the finance ministers, the economics ministers, the social affairs ministers, and the employment ministers. So we will organize that on the 12th of March of next year. So there will be a jumbo meeting of the finance minister, the economics, the ECOFIN filière, and the EBSCO filière. And me and a number of colleagues, we are preparing that by really working on that argument that investment, intelligent, well-organized investment in social policy, but also in healthcare, is a productive asset and we should be able to continue that kind of investment also in the framework of the EU's new economic government. So that will be a very important debate. However, I would also like to say the message is invest and reform. And let me come back a little bit, if I may, to what Nicolas said. Nicolas, we are investing in healthcare. If I take the salary of someone who starts in the Belgian healthcare system, a starter, a nurse, or even a clerk, we increase the salary of a starter beyond price indexation, so in real terms by 11–12% if you compare today's starting salary with 3–4 years ago. So their salaries are not reduced. Huh? We increased them very significantly. Secondly, the number of staff over the last 10 years has been increased significantly. So we do invest and we should invest and it should happen everywhere, I agree. However, the pressure on the system is such for fundamental sociological and demographic reasons that will not solve the problem. So we must reform and we need thorough reform. Indeed, for instance, AI can be extremely helpful. You can replace radiologists. We will have shortages of radiologists in a few years' time. But you can replace them and do a better job. Now, and there I come, and if I may, I'll stop there. I come to the Irish representative of the health and care sector. Yes, indeed, I do believe that the EU can be at the frontier of thinking about reform. And that's exactly what we want. And then we will take on board, this is part of our program, the lady that mentioned the EU's Beating Cancer plan. We want a stock-taking exercise because there's more to do on cancer. We want a stock-taking exercise on the EU Beating Cancer plan. But also we want to use that as an example how you can work indeed also on healthy lifestyle, because I won't go in all the aspects of the healthy lifestyle you mentioned, but contrary to what people may think, the EU has important legal competencies in domains where we are about lifestyle, tobacco, alcohol, you name it.
I wanted to bring Lubna in here because the
Okay.
clock again
I
is
stop
against
here.
us. Lubna.
Well, thank you. And I think if we hear many questions and also many insights here is linked to actually solutions that we can already implement today with the technology we have. So the efficiency elements, we are the capacity problem, and we know that actually as an engineer, I would recommend that as step one, phase one, let's use AI and technology to drive efficiencies, patient triage, serious cases to specialists, non-serious cases in a different pathway. Let's address the efficiency. The data sensitivity there is less of a problem, and we can already implement it. And still we have the human in the loop. While we are executing phase one, let's have a phase two, where we're actually addressing the bottom-up approach, bringing the patients, making them part of this. They own their health data. So instead of trying to build big initiatives, and I'm so excited by the European health data space, but we've been talking about it for 4 years. Where is it? So really making the patients part of this and having this AU health app. Let's call her, we called her in Berlin, in Dublin, Sarah, for example. Let's get the patients part of this, donating their data to train the system and already open some hospitals in Europe to be the sandbox environment. Next to the normal workflow, to have the AI just to check a Turing test. How good is the AI in the radiology, in dermatology, in ophthalmology? And then just bring the facts. If we don't get the facts, even if we tested those systems in the lab, let's get them to run in reality. That will be phase two as an engineer. Getting the facts, getting the data, and then making the decisions. When to go live, how to go live, launches, which countries, which member states will be part of that. And then number three, and then come the holistic. Then we go beyond data about managing disease and preventing disease, but also monitoring, and we're bringing what we always had, nutrition, physical activity, and we are driving this dream.
I know, Frank and Nicholas, you want to come back, but I'm going to go back to the floor for the moment for another batch of 3 interventions. So hands up, I see a hand back here, and another one over here. So the mic here first, please.
Thank you very much. My name is Anna Knoll. I'm working at ECDPM at the Migration and Mobility team. It's a think tank focusing on global development issues. My question is to Nicholas or Frank. You mentioned the need to also look at mobility and migration to some extent. So my first question, with all the measures relatively seen, how important is that component next to, replacing maybe radiologists with AI or looking at domestic workforce? And then the issue of the fairness of recruitment was mentioned. That's particularly sensitive in the health sector. We have now this morning talked about at the table of Europe-Africa relations on coherence issues and the issue of investment with Global Gateway, for example. So my question here is, how can we ensure that we don't, on the one hand, promise to our partners that we invest in local workforce? At the same time, we have bilateral agreements of EU member states recruiting actually health workers. So what's the role of the EU in ensuring that it is a fair partnership and it is coherent?
Thank you. So we have just over 10 minutes left. I would like less questions from the floor and more recommendations, please. So more hands. Okay, just over here.
Yes, sort of building on a lot of what's been said before, I think it's really important that, how do we better integrate, to integrate health in all policies and equity in all policies? Is there a way to tie those things together? COVID certainly demonstrated that. And another recommendation, I think, and that's where technology can come in, but with this migration, health, how do we track health workers and their competencies when they move countries, and patients, whether it's refugees coming from somewhere else, how do we track the care or their conditions? So utilize help for that.
Okay, and then over here.
Okay, a little bit of question and also can be used as a suggestion. I'm Andrea from the Mission of Argentina before the European Union. And we were really glad when the strategy of the Commission concerning medicines came out, because it's the first time we see the framework for international cooperation in an instrument. So my question is, in Argentina, for instance, we have very good quality doctors, and healthcare people. So if it wouldn't be useful in thinking of a frame of cooperation with displacement, it can be even temporal because we are on counter seasons. And that would also solve this problem of not depleting the medical care of another country. So if you can think of a system of mobility, keeping them as a roster, it will also help their qualification and their skills. And I think it will be a win-win.
Okay, now I'm going to break my own rule of engagement and go for more than a batch of 3. So there were a couple of more hands. Okay, we have Debating Europe over here. Sophie?
Thank you. So I'm Sophie. I'm a facilitator for Debating Europe, and so I've been listening to the voices of citizens on the main global challenges that are there today. So something that got raised up there is that we need to talk more about the psychosocial state of our societies, rather than just the economic well-being. Like COVID had an impact on the concentration levels of people when they had to do teleworking. Heat waves have an impact on the efficiency of the people. So they find it important that there is also invested on the well-being on the work floor, because at the end, this will also have an impact on the productivity and the economy.
Great. Okay, a couple more hands I saw. So this gentleman over here. Just behind here. Yes, this gentleman here.
Thank you. Jan Lekam, Chief Executive of Rare Disease Europe, EURORDIS, and also founder of the International Rare Disease International. So it's not about to talk about rare diseases in that context, but really to call in terms of proposal for the next mandate of the Commission to really work on the European Health Union. We're really discouraged to see that after the COVID, it seems that it's too much back to business as usual. And while in fact within the current treaty and with political will, we can do much more on health. We need a bigger budget within the European Union for the agencies, and we need a stronger directorate of health than what we have today, which is absolutely understaffed to do the thing. We need also a long-term view. We need much more foresight on health. Everything is decided looking at 3 years, 5 years. That's nonsense. We need to look at 10 years, 20 years to create the change we want to see. We can tackle much more topics which have a high community added value of working together, still sticking to things without reinventing the wheel, to the SDGs, universal health coverage, clear objectives that we can achieve. So that's what really we would call for.
Great. Couple more hands. Recommendations rather than questions, please. There were a few other hands there. Where did we okay, there's here. Yes.
My name is Petrica Dulghero. I work with the Roma communities in Eastern Europe and the Balkans. And my challenge on the field is that I believe we're speaking about a Europe with 2 speeds when it comes to this. They're very rich and smart people, and then we have a lot of people who feel betrayed and left behind. And when it comes to migrants or when it comes to vulnerable communities, in the past, people have really benefited from data collection. Like the Roma community have been, data collected and then they've been sent to the Holocaust. So I think when we're talking about the social contract, I think we have failed so many people in Europe and so many people who are really not convinced that we represent them. And I think it's going to be very difficult to convince these people to give their data. So I don't really have
Do you have a recommendation?
I don't. I think that the whole point is to really bring them into this sort of forum, into these sort of conversations. And I believe it's really, really difficult because they don't live necessarily in Brussels. Nobody actually wants to go into a slum house or a ghetto. Nobody actually goes there to listen to them. And I really think it's important to bring them in because otherwise terrorism is going to be, slowly coming from those.
Okay, so more inclusive conversations. Last show of hands, because we're down to the last minutes before we go back to the panel for closing remarks. Any more hands? No more recommendations? Not even questions? Okay, back to the panel. For the last, we have 6 minutes. So all 4 of you have about 1.5 minutes to respond to whatever you heard in the room and make some final comments. But I also have one closing question of my own to you all, and that is, what is your one ask for the next EU mandate in terms of this? Your one demand, yes, for the next EU mandate. Lubna, let's start with you.
Get to member states to really now collaborate for this. We cannot always have the same. It's the member states' dilemma, because healthcare and in COVID, we had to work together. And we have to cross that bridge now and open up these sandboxes. We've been talking about it since my time in the high-level expert group on AI, that we need AI sandboxes in multi-member states, not just one. So, and having the initiative European Health Data Space, that could be a good bridge, but finally get us there. I think that's one of the key. If we get that, that will be really great.
What about a response to the gentleman who raised that question of the inclusivity of it and populations that may be wary of giving their data?
I think that will be really great. I mean, engaging the public to donate their data. We know that is as entrepreneurs, that's what we do. Go into the consumer directly and asking for data. I think if we have a multi-approach here, both top-down from, let's as member states agree, we have the European data space, we have, let's open up some hospitals as sandbox environments for these algorithms, but then bottom up, and I would say at phase 2, because you need to start collecting the data and making, at the end, the only unified healthcare app, AI app that can work is the one that is from the people. People are willing, are sharing their data and taking the benefits. If you want to opt out, then you're not part of it. If you want to share your data, you opt in, then you get the benefits of the automation.
Andrea, over to you.
Very briefly, I'll take a comment from a lady, and apologies if I hammer on that. No, the story of health in any policy is 15 years that I had that, it didn't work. So time to change. Next mandate, a policy for health, fully integrated, they're really only comprehensive, they use innovation as an enabler for change and transformation.
Great. Okay, Frank, back to you.
Yeah, my objective is that European Health Union, in a fully fledged and complete sense, is again one of the top issues in the Commission's strategic agenda for the next 5 years. That's what I'm working towards. Secondly, addressing the issue of equity, I would also like to develop a strong link between the European Health Union on the one hand, and some of the principles enshrined into the European Pillar of Social Rights, notably principle number 16, which is about equal access to quality and affordable care and healthcare. And if we can bring that together, we can, let's say, define a challenge at EU level, which combines the health union idea with issues of equity and fairness. Then finally, on data, I have a more radical view than Lubna. No, I really have a more radical view. I think the default position is that data are public. That's the default position. I created a Belgian health data agency to facilitate the secondary use of data, also for private actors. Parliament was nervous about that, but I forced it through. I created a health data agency, and we are really working on this. And indeed, the default position is that you share your data. Default position is that medical doctors stop their conservative fights against sharing of data with other people in the profession. And that's the fight we have to organize. also at EU level. I do think that European health data space regulation is an important step forward. I think we should agree on it. I hope that will be settled relatively soon. Otherwise, it's business for us in the next 6 months. But it is a public issue. And I think that finally, because I did not answer the lady in green's question on the patient, sharing health data is fundamentally also about empowerment of patients.
Right.
And we should explain it also in that way.
Great. And the last word, Nicola, to the Commission.
Now, well, just one remark on the care economy. I think we should be aware, and this is happening, of the importance of the care economy as a part of our economy. But this is an economy that cannot function like any other sectors. It's not like the automotive or, I do not know, a sector. It's a very special. So we have to also rediscover a bit the special rules, the values of interest, the public interest services, and promote that and take into account that. The gender issue is fundamental. This, if we do not really tackle the issue of working conditions in the care sector, because 80% of those working there are women, we should not talk about gender equality. So I think this is something we really have to continue. By the way, we have a recommendation on care and long-term care, which takes in all these aspects of quality, but also of working conditions, and especially also the gender issue. Now, I would say, with Frank finally, that for the next Commission, health union is important, but this will only work also if we have a different look at care and healthcare. So in our budgetary policies, this has to be integrated. And that's what we discussed yesterday about social investment. My last remark is about finance. Yes, I agree, we have to reform, but this means also there are in the healthcare sector enormous economic rents. Enormous economic rents. And this has to be tackled because this makes the financing of our health system more and more difficult. We have also to attack these economic rents.